Our final speaker is Bunty Layboyd. Bunty is a midwife who is very well known in the Bristol area and very well known in the midwifery community. She's passionate about being with women, and she's also passionate about gender issues which affect how women access and experience maternity care. She's worked in many settings and she stays true to her core beliefs as a midwife. And I'm very privileged to know Bunty, and I think you will enjoy her next presentation to you around how her understanding and her experience of being a midwife can improve women and their families' experience of maternity care. Over to you, Bunty.
Hello, thank you for joining me for my talk today, which is Navigating Care for Same-Sex Couples. My name is Bunty Layboyd. I am a midwife based in Bristol in the UK, and I'll start by just giving you a little bit of background about myself. So I have been practicing for nearly 5 years. I have a professional interest in inclusivity for the LGBTQ plus community in maternity. It is something that I'm really passionate about, and I feel we don't talk about enough in maternity, and is something that I think that we should be pushing to the forefront to create a more inclusive maternity system. On a personal level, I am also in a same-sex relationship. So I am married to a woman who also works in healthcare. And I feel this is really important, this significant of lived experience. And although I'm really passionate about all people in the LGBTQ plus community in maternity systems, I will predominantly just be addressing female same-sex couples or lesbian couples, because I feel very strongly that the concept of lived experience is actually what qualifies you to talk about discrimination of a particular group. And through the talk, I may use the terms lesbian and female same-sex couples interchangeably, depending on which pieces of research that we're actually looking at. So during this talk, we're going to look at the qualitative research that we have available surrounding maternity care for same-sex couples and how the heteronormative system actually harms them, and what we need, what we mean by heteronormative and how we can do better and improve. And so firstly, let's just have a look at the overview of the research that we do have available. So Stonewall published their LGBT in Britain healthcare report 2 years ago, and these statistics are sadly really unsurprising. So almost 1 in 4 LGBTQ plus people witness discrimination or negative remarks made against them or other people in the community by healthcare staff. So that's nearly a quarter of people. And although the report didn't specifically cover maternity for same-sex couples, we do have other pieces of research that we can then have a look at. So we know that from the births by parents characteristics report published by the ONS, that there were 1,791 births registered same-sex couples in 2018, and that the HFEA reports that 3.1% of all IVF undertaken was by female same-sex couples. And that data and that report also commented that the number of same-sex couples that they see having fertility treatment in the UK goes up hugely every year. And so we know it's an ever-increasing number. What becomes difficult to determine here is, with the evidence, is if we are improving our healthcare systems by updating our practice, and there isn't exactly a plethora of evidence available. So we don't have lots of evidence that addresses the needs of same-sex couples. What is there? could arguably be described as slightly outdated if we consider the rising number of registered births to same-sex couples. We'll have a look at a couple of the studies. So Burns et al. In 2013 looked at co-mothers' experiences in maternity. And what they noted was that although people felt generally included, there was still a sort of underlying current of that feeling of being in a what they described as heterocentric, and what we are describing today as heteronormative system. And a heteronormative system is one which has been built on the concept that being heterosexual is the norm. So in the context of this system, in maternity systems, we have created a maternity system which considers heterosexual and cisgendered people and relationships to be the norm. And that means that anything else gets squashed into whatever space we have left to accommodate them with. So already we're starting on the wrong foot by welcoming same-sex couples and other people from the LGBTQ plus community into a system which isn't actually built for their unique needs. And what's interesting to think about is this is often considered as a positive aspect of acceptance within healthcare. So another piece of research which is really interesting is was done by Goldberg in 2013. And what they identified was that healthcare professionals felt it was beneficial to treat same-sex couples and same-sex parents in the same way as they would heterosexual parents. Superficially, it appears to be accepting and inclusive, but if we consider the fact that our midwifery training and our maternity systems are constructed in this heteronormative manner, practicing in this way actually achieves quite the opposite. So we're already making people feel like they're on the margins. Some research actually suggests that same-sex couples would benefit, and they do want care which is specifically created for same-sex couples. Rondell et al. Looked at how heteronormative communication between the midwife and parent relationship can be really harmful and affected by that heteronormative system. And what they found that was the incorrect assumptions that healthcare practitioners made led to feelings of embarrassment between not just from the couples themselves, but actually the midwives as well. And what they suggested was that midwives would benefit from additional training into how to communicate with same-sex parents. And they also suggested that same-sex couples also want antenatal groups which are focused specifically on their individual needs and their parenting needs, a whole other set of parenting aspects to contend with, like fertility. So we know then that same-sex couples aren't fully represented, or they don't feel fully represented in maternity care. So let's consider ways that we can try and address this. So as suggested in the evidence, midwives would benefit from additional training. So let's start right at the beginning with students. Arguably, younger generations are more familiar with inclusive language, but not all midwifery students are of a younger generation. So we know that we have students who are mature students coming into the midwifery degree. So I'll give you an example here. When I was a midwifery student, I had a teaching session led by an antenatal teacher, and they were demonstrating how to teach an antenatal class, and they commented that they get men and women to go in separate groups. So I asked, what happens if you have a same-sex couple? And they said, I get the man lesbian to go with the men. And for some of you, that probably sounds really horrifying, but I overhear that sort of problematic language and experience that language used all the time. And this needs to change before we even contemplate considering ourselves to be an inclusive maternity system. But also registered healthcare professionals, which most of us are. We could really benefit from in-house training, and this could be really easily incorporated into the training that we already undertake. So things like mandatory training days, giving healthcare professionals the opportunity to address their own bias and consider the language they use as being potentially harmful in a safe environment. And going back briefly to the Stonewall report that we mentioned earlier, 1 in 7 people avoid treatment altogether because they're fearful of the discrimination they face, and that's not good enough in in 2020 when we consider ourselves to be generally inclusive. And so you might be thinking to yourself that you're not homophobic, that you don't use homophobic language, you don't say harmful things to make people feel discriminated against. But it isn't just the outright homophobia that causes harm. Sometimes it's the smaller things. So those assumptions that we touched upon earlier. Let's take a look at our maternity paperwork, for example. So when somebody is booking a pregnancy and they initially come to meet their midwife for the first time, we ask them lots of invasive questions. But the booking paperwork alone is very problematic. So we have questions like the father's details. We often only have 2 genders. We have man or woman, and with no consideration that not everybody identifies as man or woman. And even the term mother in itself can be very problematic. There's, again, no consideration to not all pregnant people identify as a woman or a mother. And we need to address that lack of representation within maternity services before we can learn how to do better on an individual level. So firstly, we need to address the systemic homophobia, and before we can then look at ourselves as individual practitioners. So if we look at how to address the lack of representation, simple things such as including photographs or videos of same-sex couples and other people in the LGBTQ plus community, that would instantly allow people to feel safe and included. And in order to make a minority group feel included, you must physically include them. And a huge part of that is through visual representation. But if you're going to do that, start firstly by actually consulting the community. And I cannot stress this enough. So we don't have a huge amount of qualitative research that we can look at, but what we do have is a whole community which we can consult, let that community lead changes, make space for those voices and listen, and properly stop to listen to see what they actually want from their maternity systems. You may also want to consider the creation of a specialist midwife whose expertise is for inclusion for the LGBTQ plus community. It's very important that this person understands firsthand, though, what it's like to be part of the community, but also what it feels like to have discrimination. And that leads back to what we were talking about earlier, about that significance, that first-hand experience. And it's that feeling of discrimination that fuels the drive for change and ultimately will then work towards eradicating this discrimination. So this person can undertake tasks such as creating and maintaining guidelines and policies. And that's a really important part of guidance for individual healthcare practitioners. That person can also create training programs and lead those training programs for healthcare professionals to attend, and maybe including first-hand stories because they are very eye-opening and they're very powerful. This role could also incorporate helping to move away from the heteronormative language that we use in maternity, so adjusting our leaflets and the data collection tools used. We also need to stop making assumptions, and the evidence would suggest that that's one of the most harmful things for people in the community, that having to actually come out, so to speak, every time you meet a healthcare professional is quite demoralising. And this is reiterated where the research is available. It seems like such a small change to your individual practice, but it makes an enormous impact for the people that you're caring for. And I'll give you a little example there. So a couple of years ago, I took my wife into A&E, and it was a very stressful situation. A&E, as you know, is very busy. It was the early hours of the morning. We've been there for quite a long time. She was in quite a lot of pain. She's not the best patient. And a nurse came into the room to ask her some questions, and one of them led to my partner, my wife, sort of waving her hand behind her to pointing towards me and saying, my partner is a midwife and works in the unit. To which the nurse then replied, a male midwife, that's unusual. So, despite me being sat with her, and I had been for several hours, and her actually, waving her hand towards me, that nurse then made the assumption that not only was I not her partner, but also that she was married to a man. Um, Please feel free to email me if you want to ask any questions, or if there's anything that I can help with when you're trying to make changes, not just to your individual practice, but to your organisation as well. And thank you for listening. I really appreciate it. And in maternity, we often have to make trusting relationships very quickly and spontaneously. And sometimes they are life saving relationships that are incredibly important to build on very, very quickly. And these mistakes, these incorrect assumptions that we make, can really hinder and break down those relationships, which are all so very important. A part of this is a habitual and a social norm, but then we need to look at how we move away from this. And if there is something that I'd like you to take away from the talk today, it is how you can make those changes as an individual by not making assumptions, by going away and educating yourself. So look at the research, attend talks like these, and listen to the community when they are telling you what they want from their healthcare, and what makes a difference to their care, and how you can improve your care to be more inclusive as an individual healthcare practitioner.